Dr. Riley gave a great initial overview of the biological underpinnings of what constitutes primary and, more commonly, acquired resistance. The threads of discussion throughout the morning and really throughout the day all overlap, hopefully pretty seamlessly. And the next topic that we'll be covering is the clinical implications of how we might manage acquired resistance. Many of you know Dr. Jared Weiss. He is an assistant professor of medicine at the University of North Carolina School of Medicine in Chapel Hill, thoracic oncology and head and neck specialist there. He's also the vice president of GRACE, has been involved for several years, and remains very committed to GRACE and its leadership. So Dr. Weiss will be speaking on life after Erlotinib, what's next, but really it's more than just one drug or even one target, but the real premise of the various ways that we might clinically approach acquired resistance in terms of local ablative therapies versus systemic therapy changes, et cetera. So with that, let me bring on Dr. Weiss. Thanks.
Thanks, Jack, and thanks, everyone. It's really quite a thrill to be in a room with so many people who care so deeply about this subject together, both patients, caregivers, and some of my personal heroes in the space of getting better therapies. So I actually changed the title of my talk to Life After First-Line Targeted Therapy, What Next?, to reflect what Jack was just saying, that these principles that we learned from the world of EGFR resistance with Erlotinib have really translated quite well into other targeted therapies and mutations. So this is data from a very famous trial in our world called Ipass. Ipass randomized patients newly diagnosed with incurable lung cancer to the standard chemotherapy regimen at the time, carboplatin and paclitaxel, and a challenger regimen, gefitinib. Gefitinib is another EGFR TKI like Erlotinib or Tarceva that happens to be in more prevalent use in Asia and Europe, but you can think of it essentially as equivalent to Erlotinib here. And once we learned about the EGFR mutation, patients in this trial were subdivided into those with mutation and those without. And what we learned was that cancer control for patients without mutation was superior for chemotherapy. Oh, I have a laser pointer. Academics love laser pointers. That's great. They're like shiny, flashy, shiny objects to us. But in patients with the EGFR mutation, not only were there toxicity advantages to the targeted therapy, but cancer control, shown here in the green arm, was actually better. And I think from a patient perspective, listening to many of my patients, the biggest advantage here isn't just the duration of cancer control, but the demedicalization of life, that an oral therapy allows people to travel, to be with family, instead of spending every few weeks in my infusion room. Only 5 years later, our perspective on these curves are a little bit different. And I think many of us realized this at the time, but now even more so, we're saying, well, 10 months, that's nice. This may be better than chemo, but that's not a particularly high bar being better than chemo. That 10 months of cancer control really, from a human perspective, is not good enough. And now, what next? And the reason we have this forum today is that we actually have some answers to that question. Same story plays out with ALK and CRizotinib. This is data comparing first-line patients with chemotherapy to CRizotinib. And like the second-line data that Dr. Riley showed you, shows superior disease control for CRizotinib compared to chemo. The number is actually very similar. Median progression-free survival was 11 months with CRizotinib as compared to 7 months with chemotherapy. So again, better than chemo, but I think all of us in this room would agree not good enough. It really is sticky. Okay, so my first option is to learn from the politicians and kick the can down the road. My wife says I'm not that funny, but this crowd is easy. This pointer is not. Can you help me go forward one? Okay, so this is a slide frankly stolen from Jack Weiss. So thanks not only for being here, but for the ideas for me to steal. And it's a conceptual slide. So on the y-axis here, we have burden of cancer. So everyone's starting here with 100% of the 100% of the cancer at the start. And on the x-axis, time. And so what happens, patient with EGFR mutation going on Erlotinib or ALK or ROS1 rearrangement going on CRizotinib starts with their total burden of cancer. And what we typically see on TKI is rapid shrinkage of cancer, right? That story we're all familiar with. All of us who give these talks come up and brag. We show the slides. Cancer was terrible. Now the lung looks clear, right? And graphically, that's what we don't take my laser point away. Okay. Graphically, we get to here where the cancer has come dramatically down. Every patient and every doctor wished that the cancer came to zero. Unfortunately, with currently available drugs, that doesn't happen too often. What more often happens is that we get this valley or plateau of stable disease for a while, and then unfortunately, at some point, typically around 10 or 11 months, the cancer starts to grow. And the pattern shown here is one of the patterns that we see where the cancer growth is very slow. Right? Where you have a pace of growth that is so slow that it may not hurt the person anytime soon. And so one option in this situation is to continue just ignoring that progression. Watch it very carefully, monitor it, but continue exactly what you're doing. The patient for whom this approach is most appropriate is if the cancer is nowhere near a major organ where it's going to threaten duration of life or quality of life, where there isn't a high symptom burden at the time this is going on, and the pace of the growth is something like this, where it's not too quick. Here we go. In contrast, if the cancer is taking off, if there's very rapid growth, that's not the time to just watch. That's the time to do something different. So Dr. Oxnard has shown us what this looks like graphically. These are going to be a panel of CT scans. CT, as most of you are probably familiar with, slices you like a hoagie like this, and you can scroll up or down. Things that are not dense, like the air outside of the patient's body, are black. The air in the lung is black. And things that are white are more dense, like bone, blood vessels, or in this case, the cancer that we're following here. So here the patient starts on TKI, and as most patients do, has a nice response 3 months later. You can see that cancer burden is decreased. At 14 months, the patient has progression by our formal criteria called RECIST, a system that many of us have issues with that I'm going to leave aside for the day. But formally, this patient has progression. But if you look at it from a common sense standpoint and compare this to this, you can see that the patient actually has much less disease burden than when he started, and such a small burden that it's unlikely to threaten his well-being in terms of symptoms or life itself anytime soon. Patient and doctor team elected to continue on targeted therapy. At 18 months, here's what it looks like, still much smaller than the baseline cancer. We keep going. At 2 years, here's what it looks like. I double-click, that's okay. By 30 months, we're right around the size perhaps where we started. Here's what it looked like at 35 months. And at 37 months, the decision was made to finally stop TKI. One more forward, please. And at 39 months, more than 3 years later, the patient first experiences a symptom, which in this case was shortness of breath. So this is a sort of extreme example, but one that I think illustrates a principle helpfully, that for slow progression, simply following very carefully and continuing the targeted therapy to slow things down is one very valid option. This is a plot called a swimmer's plot. Every horizontal line there is a patient who continued Erlotinib past progression. There were 42 patients in this series who did so. In the dark orange here is the original Erlotinib. The hatched orange is the Erlotinib past progression. In this series, almost half of patients were able to get another 3 months out of Erlotinib. and 21% were able to get more than a year out of it, some of them with a little help from radiation, shown in the R's, or surgery, shown with the S's. Same thing happens with crizotinib. The original crizotinib studies allowed patients to stay on crizotinib if the doctor felt that they were receiving benefit. 62% of patients on these studies did so. 38% did not. And these are the survival curves. The top curve, the superior one, is patients who stayed on crizotinib. That was a median survival of about 16 months. Survival was much shorter for the two curves here of the patients who did not continue on crizotinib past progression. Half got some alternative therapy. As I'm sure you can guess, that's the curve that did better than those who were not able to. There are two very important caveats to this. One is that there were no second or third line ALK inhibitors at the time that this data came out. So in terms of ALK-specific inhibition, this was it. The other is that people who were able to continue on it were almost by definition a superior prognosis group. Nonetheless, I do think that it illustrates the principle that with ALK, just like with EGFR, and I'm going to guess it'll play out the same story with ROS1 and many of the other targeted changes, that there can be benefit to continuing the targeted therapy past the time when the scans show our formal criteria for progression. Option 2, weeding the garden. All right, I'll take this one out. It's the first time I stole that cartoon, and it's not getting as much of a reaction. So before going there, I want to steal a concept from Dr. Gandera's slides about 3 different kinds of progression that I think Dr. Riley has already started to explain, and so I'll go through a little quicker. This is classic progression. This is what we saw for decades on chemotherapy. Patient goes on chemo. At the beginning here, in every doctor's fantasy, there's a complete response. Of course, that's not every patient, but to illustrate the principle, let's say we've had a dramatic response. And then when the drug stops working, it stops working. Every site of cancer is growing, and perhaps there are a few new spots there. There are 2 new patterns of progression that we're seeing much more commonly with targeted therapies. First is oligoprogression, one that I have particular interest in. Patient goes on drug, gets benefit, and then we have progression in just one spot. So this happens a lot. Dr. Riley touched on the heterogeneity of resistance, that you can have resistance in some places, not resistance in others, that the mechanisms of resistance can be in different places. We see this pattern in the real world, where just one or just several spots are growing because of whatever resistance change it is that they have, and the rest is beautifully controlled with whatever targeted therapy the patient is on. Dr. Riley also explained to you beautifully the pattern of sanctuary site progression. This is when the drug may be working beautifully in the places that it can get, but it's not getting in some place like the brain. And we see this pattern again commonly with our new targeted therapies. And so when we talk about weeding the garden, we're going to talk about systemic progression as the worst idea to do that, but these latter 2 conditions as places where weeding the garden may well provide clinical benefit. Personally, my favorite way to weed the garden, my favorite gardening tool, if you will, is radiation, at least for EGFR mutation. The data, I think, is not quite as well established for ALK, but for EGFR, there's good data that there is a higher level of radiation sensitivity for EGFR mutated lung cancer cells than for non-mutated cells. At left, we see the lab data. At right, we see real human data from actually from this city, showing that local control in patients with EGFR mutation is superior than for patients without EGFR mutation. Surgery and other modalities are also reasonable ways to weed the garden. It has been tried. Here's the memorial data on 18 patients, all with EGFR mutation, mostly treated with surgery to remove those sites of progression, with a median time to progression of 10 months. This was also been looked at retrospectively by the Colorado group. They looked at a mixed series of EGFR and ALK patients. And what they showed was an additional disease control of 6 months. I apologize. I mucked up the animation on this slide, so I'll just have to tell you a concept that I wanted to get across. Can I go back one? Which is that they did subdivide their results by patients who progressed in the body and the sanctuary site progressors in the brain, and the results were superior in the sanctuary site progressors. So that when it's brain-only oligoprogression, that may be a particularly promising time for this approach. And I apologize for mucking the slide up. Going forward, we are prospectively studying this approach in patients with EGFR mutation. I'm grateful to have some wonderful collaborators, several of whom are in the room with us. Patients with EGFR mutation who have 5 or less sites of progression get stereotactic radiosurgery to those sites of progression and then go right back on Tarceva for the rest of the cancer to try to prove prospectively that this approach that worked retrospectively does work. And I think we're getting to questions at the end, but happy to address it then. So Dr. Riley showed you his data on FLAIR that I'm going to use as an introduction to the concept of continuing erlotinib when you switch to chemo. So one validated option, perhaps the most standard option actually, after TKI stops working is to go on to chemo. Dr. Riley showed you already what can happen, so I'll flip through it quickly. When you come off of TKI due to progression, can I go forward one, please? Despite the fact that the TKI wasn't working up front, things can get much worse when you come off of it. And going forward once more, things can get a little bit better when you go back on. And so many lung experts have used this as rationale of why when we choose to switch to chemo, that the TKI should be continued. Same thing happens with ALK and CRizotinib. In the top panel, we see cancer well controlled, both in the lung here and in the liver. At 15 days after coming off CRizotinib, we see a flare of cancer in the lung as well as in the liver. And Dr. Shaw has made the comment before that she's seen more flare in ALK with CRizotinib than actually with EGFR in erlotinib, and I sure believe that. So Dr. Sarah Goldberg has shown us what happens, retrospectively at least, when we do this, when we continue the TKI while starting chemotherapy. These are waterfall plots. So as Dr. Riley told us earlier, every patient is a vertical bar. Anything north of the 0 line is bad. That's growth, with the numbers representing percent growth. And anything south of it is shrinkage. In the cancer world, we had to pick a bar somewhere for response, and it happens to be 30% shrinkage. I'm sure patients with 29% shrinkage derive some very real benefit, but we had to pick the bar somewhere. So responders shown here in orange. And what Dr. Goldberg was able to show is that the response rate when you continue the TKI is much higher in her series 41% as compared to only 18% with chemotherapy alone. Go forward one, please. Next slide, please. Back one. Frozen. I watched that with my nieces. It was a great movie. Because of avoidance of flare reaction and that higher response rate, I think most thoracic experts recommend continuing the erlotinib when a patient switches to chemo. I actually tend not to in my practice. And here's one of the 2 reasons why I don't. In Dr. Goldberg's series, neither progression-free survival nor overall survival was actually better. So the response rate may have been higher, but people's cancer wasn't controlled longer. They didn't live longer. And here's perhaps the more important reason why I personally tend not to, although it is the dominant approach amongst people who know what they're talking about. That reason is side effects. Multiple series have shown us that it is safe to continue the TKI with chemotherapy. Certainly, at least with EGFR, that's been shown, gosh, at least a half a dozen times now. The problem in my mind is that there is an increased rate of side effects, particularly focused on rash and diarrhea, but also to a small number, a lung problem called interstitial lung disease. And so this data happens to be from a very famous study in our world called Tribute, but it just shows you highlighted here the rash and diarrhea rates are a bit higher with TKI compared to not. The approach of adding TKI to chemotherapy is being prospectively studied in 2 phase 3 trials. This is the European and Asian trial called Impress. Patients in this trial get gefitinib because of where the trial is being done. And they either continue on chemo plus gefitinib or chemo alone. Again, because of geography, the platinum here tends to be cisplatin, where in the US, forward a slide, please. We tend to use erlotinib as our TKI for EGFR and carboplatin as our TKI. Nevertheless, the idea is the same. It's patients who've progressed on EGFR TKI getting chemotherapy alone or chemotherapy plus TKI. And these 2 trials should really answer the question for us of what the advantages and disadvantages of the approach are. When TKI is not continued with chemotherapy, there are 2 series that suggest that there may be benefit to coming back to it at some point later. This is Steph Heon's data, again retrospective, showing that patients who came back to TKI after having been off it could get another 3 months or so out of disease, and at right, a Japanese series showing sometimes much longer benefit. So I had the privilege today of speaking to you about the lowbrow approaches to acquired resistance. Chemotherapy plus TKI, brute force weeding the garden with either radiation or surgery. Some of my smarter colleagues are going to talk to you about the more elegant approaches that can be taken, and frankly that for the most part I think are going to define a lot of our future here. You're going to hear from Dr. Pasiani at the EGFR breakout session on the 3rd generation EGFR TKIs. These look incredibly promising, but they do require, at least at this point, repeat biopsies to get on study, and almost all of them require the T790M resistance change to get on study. And so they're wonderful for the 60% of patients who have that change, but the other 40% is quite meaningful, especially when we're talking about the most commonly actionable mutation, EGFR, at 15% of adenocarcinoma. Dr. Shaw is going to talk to you later about the 2nd and 3rd generation TKIs. There are at least 4 or 5 of them that will come at the ALK breakout session. Dr. Melissa Johnson is going to talk to you about the combination trials for EGFR at the EGFR breakout session. More on the ALK combination trials at the ALK breakout session. And finally, I'll note that there are answers other than one specifically targeted to the change that is there. The other options, including chemotherapy, including other promising trials, particularly immunotherapy, have at least as much promise for patients with targeted mutations as those without it. So to summarize our options, we can kick the can down the road. This is an appropriate approach when the cancer progression is very slow and it's not threatening any major organs. We can locally ablate spots that are growing, then restart TKI. This is most appropriate when there are only 1 or 2 spots that are a problem and everything else looks beautifully controlled. We can continue chemotherapy plus TKI with the advantage of minimizing the risk of flare reaction and increasing the response rate, but at the cost of some diarrhea, the cost of some rash, and not improved survival. We can go to chemotherapy alone. There are 2 caveats, though, if that approach is taken. First, you need to start quickly. In Dr. Riley's series, I believe that the quickest flare was at 3 days, if I'm not mistaken. And so a reasonable approach is to make that washout interval on the order of 2 days when this is done outside of a trial. To me, this makes common sense as the half-life of erlotinib is only 8 hours anyway. The other caveat is that if you do go to chemotherapy alone, that it may be worth coming back to TKI at some later point. There are a lot of novel combination therapies with a lot of promise coming out, both for ALK and ROS and for EGFR, and you'll learn more about them today at the breakout sessions. There's some really elegant science that's led us to next generation TKIs that seem to have at least as much, if not more efficacy than the original generation, and some with much less side effects. And finally, don't forget about other clinical trials. While I think immunotherapy isn't the be-all, end-all answer to cancer, as many of us had hoped it would be, there is real efficacy there, and these and other trials are worth considering. I thank you for your kind attention.